It's my great pleasure to welcome Danielle Giovenco. Today, Danielle joins us from the far reaches of Rollins in BC's, but she's also an honorary faculty member at the Desmond Tutu Health Foundation in the beautiful city of Cape Town, South Africa. So Danielle, I'm not going to go any more than that. Welcome, and thanks so much for being with us, and look forward to your presentation.
Thank you. Okay, so we can make this like slightly more interactive since this is a smaller group. So if you guys have questions or anything's not clear, just interrupt me, and happy to touch on things during the talk. Okay, so today I'm going to talk about a few current and planned research projects aimed at addressing social and structural barriers to HIV prevention and care among South African youth. So first, for a quick introduction, so my background. So I started my research career at Brown University in 2013, and I was working as a research assistant in their School of Public Health with Don Operario, who is now here in BC's. And I worked on an early qualitative PrEP acceptability study of DOMs, and this was before PrEP was even approved for use in adolescents. So this study was looking at PrEP acceptability among South African adolescents. And through this work, I gained kind of this deeper understanding of the HIV epidemic in South Africa and biomedical HIV prevention. So I developed this strong interest in understanding how we can enhance the implementation of biomedical HIV prevention among adolescents and young people in this context. So I ended up completing my master's degree in behavioral and social sciences in 2016 at Brown while working full-time in research. And this master's degree provided me with training in intervention research design and social behavioral theory, but I knew I was lacking training in API methods, quantitative analysis, and infectious diseases. So I went straight from completing my master's to starting my PhD at UNC Chapel Hill in infectious disease API. So at UNC, I worked with Audrey Pettifor, and I was very fortunate to spend the first 2 years working on projects of hers and receiving incredible EPI methods and ID-EPI training. And then at the end of my second year, I received a one-year Fogarty Award, which allowed me to move to Cape Town, South Africa to work at the Desmond Tutu Health Foundation. So I worked across several NIH-funded projects under the mentorship of Dr. Linda Gale Becker. So I spent the third year of my PhD in South Africa on a Fogarty, and then right after completing my Fogarty Award, I received an NRSA F31 fellowship for my dissertation work, which allowed me to stay in South Africa at DTHF for the rest of my PhD. Okay, so the experience I obtained implementing intervention research programs in the field in South Africa for 3 years during my PhD was really invaluable for establishing this research collaboration with the Desmond Tutu Health Foundation, who was really at the forefront of HIV clinical and implementation research. This position also provided me with a lot of support to pursue independent funding opportunities with the foundation, including a research grant through Beat Healthcare that I'll talk about today that I implemented during the final year of my PhD and during my postdoc. So after my PhD, I knew I wanted to pursue a research career and gain teaching experience. So in August of 2021, I returned to the States to begin a postdoctoral position on an adolescent young adult biobehavioral HIV T32 at Brown. And so while back at Brown, I was able to independently teach their Intro to API Methods course, which is a core course in their MPH program. Then after 1 year at Brown, the opportunity to come to Emory presented itself through their new T32 training program in HIV translational science. So I moved to Emory in 2022 to continue working with Don, as well as Patrick Sullivan and Kristen Wall. And so this Emory T32 program has provided me with funding for coursework and grant and incredible support for grant writing. And then I also completed a 1 year implementation science fellowship through the Hopkins CFAR during this postdoc. And then just this past July, I transitioned to faculty in BC's after I was awarded my KO1. So that's a little bit about my journey to get to this point. So my research focuses on the intersection between these three areas. So I'm interested in improving HIV prevention and care outcomes for vulnerable populations through interventions that address social, psychological, and structural determinants of health. The majority of my work focuses on the development, implementation, and evaluation of these interventions. And the population that most of my work focuses on is adolescents and young people, and more specifically, young women. Okay, so for a quick overview of HIV-related disparities among adolescents and young people in South Africa. So Sub-Saharan Africa, which is home to only 12% of the global population, accounts for 66% of the global burden of HIV infection and 85% of infections among children and adolescents. And 77% of new HIV infections among adolescents and young people in Sub-Saharan Africa are among girls. So to put this into perspective, in 2023, 4,000 adolescent girls and young women, 15 to 24, became infected with HIV each week globally, and 3,100 of these occurred in Sub-Saharan Africa. Approximately 1/3 of all people living with HIV in Sub-Saharan Africa are actually in South Africa, and South Africa has the world's largest HIV epidemic and antiretroviral treatment program. And in a recent, semi-recent national survey, the highest proportion of new HIV infections in South Africa was among young women, and youth also had the lowest proportion of ART use and viral suppression of any age group in the country. So South African adolescent girls and young women have one of the highest HIV risks globally, and the fact that this group is carrying such a significant portion of the global and regional HIV epidemic is both a health equity and a social justice issue. Okay, so my vision for my career is to conduct research that will reduce health disparities and improve health and well-being among youth and women. These are a few quotes that inspire my work. The one on the left sort of kind of sums up the current state of HIV prevention and care work, which is really starting to focus on the importance of differentiated services and choice for HIV prevention and care options. And then last, before we get started discussing a few research projects, I just wanted to quickly touch on my approach to global health research as a Westerner. So first, investing a significant amount of time in country, so living in South Africa for several years and now going back for a longer period, has helped me to recognize my privilege, and it has also allowed me to navigate conducting research in South Africa with the trust and the respect of my South African colleagues. This has been largely possible for me thus far in my career because I focused my work on this singular context. Next, I try to make sure the research I'm proposing is in line with local and domestic priorities, but also that the research is scalable and able to be impactful in the context that I'm working in. So that's something that's really important to me in the grant planning stage. As a global health researcher, I think we have an obligation to improve research and publication equity among our global collaborators. So I engage local investigators as PIs and co-Is in every stage of research, beginning with idea development and grant writing. And then I also provide scientific writing review for projects and papers that I'm not involved with. And then last, I try to involve adolescent girls and young women and young people in research as much as possible to ensure I'm respecting their lived experience. So nothing about us without us. And we primarily do this at the foundation through youth camp and tons of community engagement events. So this is just a graphic that I find helpful to review when thinking about planning global health research. Okay, so today I'm going to focus this talk on a few areas of research that I've pursued during my doctoral and postdoctoral training, and that I plan to pursue during my early faculty career. So I hope to grow my research career in these three areas. So the first is optimizing PrEP implementation among adolescent girls and young women in Sub-Saharan Africa through social and psychological interventions. The second is designing and evaluating novel structural interventions to improve HIV care for young people living with HIV in South Africa. And the third is leveraging the population data to model the impact of social interventions on HIV in generalized HIV epidemic settings. So the first area is optimizing PrEP implementation. So we've already talked a little bit about HIV-related disparities among adolescents and young people, but for young women, these disparities are even greater. So over half of all people living with HIV globally are women and girls. And in South Africa, adolescent girls and young women are more than 3 times as likely to acquire HIV than young men. Antiretroviral pre-exposure prophylaxis, or PrEP, can be extremely effective in reducing HIV risk when adherence is high, but low adherence, especially to daily oral PrEP, has been an emerging barrier to PrEP's effectiveness among South African adolescent girls and young women. So research identifying social and behavioral determinants of PrEP use can help inform the development of tailored PrEP delivery programs. So now I'm just going to talk about a few projects and analyses aimed at identifying some of these determinants from work I conducted primarily during my doctoral training in collaboration with the Desmond Tutu Health Foundation and Giovenco. So this paper here is from the Fogarty work I conducted during my PhD. So this was from 2018 to 2019. So I integrated a cross-sectional survey about PrEP into a larger study that was enrolling male and female adolescents who were 14 to 16 years of age and their parents or caregivers, and this was near Cape Town. So at the time of this study, PrEP was very recently approved for use in adolescents, and there were no report of parent perceptions about adolescent PrEP use. So we asked adolescents if they would be interested in taking PrEP, if they think their parent would support their PrEP use, and then we asked parents if they would want their adolescent to use PrEP. And then both groups also received a PrEP stigma measure. So there were 880 adolescent parent dyads enrolled into the study. We found that overall PrEP awareness was low, but I mean, this was early days. It was about 30%, but 67% of adolescents reported they would want to use PrEP, and 85% of parents reported they would want their child to use PrEP. So parents were more supportive of their adolescents using PrEP than adolescents thought they would be, and adolescents who thought their parent would want them to use PrEP were over twice as likely to report wanting to take PrEP themselves. And then higher PrEP stigma among both dyad members was also associated with reduced interest or support for PrEP. And adolescents actually reported higher PrEP stigma than parents, which we were really surprised to see. So I think this analysis showed us that interventions could potentially be used here to improve adolescent parent communication around effective HIV prevention tools, such as PrEP, to potentially improve uptake. So both of these studies here use longitudinal data from a study called the 3 Ps for Prevention study. So this is one of the first open label PrEP demonstration projects evaluating PrEP adherence among South African adolescent girls and young women. So this was Connie Callum and Linda Gale Becker's study. So for both of these papers here, we looked at PrEP use disclosure and its impact on adherence. So in the paper on the left, we looked at the impact of disclosure to parents, partners, and peers on high adherence, which was just defined as a drug concentration level indicating protective levels of PrEP. And we found that among younger adolescent girls and young women only, those who disclosed to a parent were 6.8 times as likely to have high adherence after at month 6 compared to those who did not, suggesting that parents may be an important support group for adolescent girls specifically. This effect was not found for older adolescent girls and young women. We think we're probably less likely to be living with their parent. And the paper on the right is the first paper's qualitative counterpart. And here we found disclosure to household members had the greatest perceived impact on adherence, both positively and negatively. And then adolescent girls and young women also described difficulty disclosing their PrEP use to their parents, and several participants report experiences of violence when disclosing their PrEP use to partners. Okay, so the last paper on this topic that I'll talk about is the paper on the left, published in AIDS, where we analyzed data from HPTN 082, which was a multi-site open label randomized trial designed to look at PrEP, oral PrEP acceptance and adherence among adolescent girls and young women in Southern Africa. So in this study, we looked at the effect of past year intimate partner violence on blood level adherence. So we found that about half of adolescent girls and young women reported experiencing any IPV in the past year at enrollment. And then in our age stratified analysis, among younger adolescent girls and young women, those who reported IPV were less than half as likely to have high adherence at month 3 on PrEP. So we think these findings suggest first that IPV prevention and care interventions are needed for adolescent girls and young women in this context, just given the high prevalence of IPV in the past year that we saw. Also, violence screening programs could potentially be integrated into PrEP delivery services, particularly among younger adolescent girls and young women, since this may impact adherence. The paper on the right is a commentary on our paper, which I chose to take nicely. And it suggests that based on our findings, we could view IPV as a valuable starting point for conversation around PrEP as a way of supporting violence-exposed young women, as opposed to a risk factor for non-adherence. Okay, so this leads me to a new grant we have in this area. So this is an R21 that was awarded in August. So I'm the contact PI in this award with Linda Galbecker, and Kristen Wall, who's at Emory, is a co-investigator, and Abby Hatcher at UNC, who was the author of that commentary, is a consultant. So we know that IPV prevalence among adolescent girls and young women in South Africa is extremely high, and women who experience IPV have a greater risk of acquiring HIV. So HIV prevention for this group is critical. From our work, we also know that IPV is associated with poor oral PrEP adherence among younger adolescent girls and young women, and that some adolescent girls and young women may experience violence when disclosing their PrEP use to a partner. So this suggests to us that long-acting and potentially more discrete PrEP formulations and modalities, such as like insertable or injectable PrEP, may have benefits to adolescent girls and young women in high IPV prevalence settings. So in this R21, we will conduct formative work with adolescent girls and young women and key informants to guide the development of a multi-component implementation strategy to link South African adolescent girls and young women who experience IPV with PrEP options, including long-acting PrEP from existing IPV touchpoints where they seek IPV care. So data collection will be guided by an implementation framework, and we will design our implementation strategy through iterative consultation with adolescent and key stakeholder CABs. The implementation framework that we'll use is shown in the figure here. So our R21 will focus on the preparation phase, which is at the top of the figure. And then we are also going to explore preferences for different PrEP modalities. So oral PrEP, the ring and CAP-LA, among IPV exposed adolescent girls and young women. So our hope is ultimately that through this work, we will learn how to equip adolescent girls and young women with resilience resources to navigate both their experiences of IPV and their HIV risks. Okay, so in addition to kind of looking at social and behavioral factors that can impact HIV outcomes, we've also started to focus on structural barriers to prevention HIV prevention and care access for specific populations. So this leads to the next area of research focus I'll talk about, which is designing and evaluating novel structural interventions to improve HIV care for young people living with HIV in South Africa. Okay, so we've already touched on that South African young people living with HIV have historically experienced worse HIV care outcomes compared to adults. So traditional HIV care services for youth in South Africa typically involve overcrowded clinics, long wait times and inflexible scheduling, a lack of confidentiality and stigma from providers, community members, and peers, a lack of adolescent-friendly spaces, and poor transitions for these youth from pediatric to adult care. This is actually a picture of Obama when he visited DPHF's first youth center in Masipumalele near Cape Town in 2013. So this center provides adolescent-friendly spaces for young people to visit and access resources like computers alongside sexual and reproductive health services. Okay, so for some background on differentiated service delivery, so more countries are revising their HIV service models, especially since COVID-19, in recognition that when a health system adopts a more responsive model of care that is tailored to the needs of various groups of people living with HIV, it can allocate resources more effectively, provide better access for underserved populations, and deliver care in ways that effectively improve care quality. So differentiated service delivery is a client-centered approach that adapts HIV services across the cascade to both serve the needs of people living with HIV better and reduce unnecessary burdens on the health system. So there's a couple types of DSD, but out-of-facility individual delivery models, including home art delivery, are a type of DSD that has been implemented in sub-Saharan Africa with some evidence of sustained or improved clinical outcomes. There's been also evidence that DSD can provide cost savings to the health system and to patients, particularly if they contribute to enhancing long-term retention on art. So Although these DSD models may confront some of the structural barriers that prevent young people living with HIV from accessing HIV care and address some of these disparities we see in HIV treatment and outcomes, DSD programs and research have been limited to clinically stable adult populations, and they rarely target vulnerable groups such as youth. And Anna Grimsrud and colleagues at the IES urge that in order to meet the UNAIDS 2030 targets, HIV care needs to be differentiated across clinical characteristics, subpopulations, and contexts. So this, in 2021, we conducted this longitudinal pilot study aimed at examining the acceptability, feasibility, and preliminary effectiveness of a courier home ART delivery model with SMS support to retain young people living with HIV in Cape Town in their HIV care during the COVID-19 pandemic. So this was one of the first studies to provide courier home ART delivery as an out-of-facility DSD model for young people living with HIV in sub-Saharan Africa. So I submitted this grant while living in South Africa during my PhD to Beam Healthcare, who put out a call for research aimed at retaining young people in HIV care during COVID by reducing trips to the clinic. And I completed the implementation, analysis, and dissemination of this project during my postdoc. So I want to just quickly acknowledge my collaborators, Audrey and Linda Gale, and the amazing study team shown here, who this work would definitely not have been possible without. Okay, so this was a longitudinal pilot trial. All young people living with HIV enrolled into the study had the option to receive the courier ART delivery service, and then they were also randomized one-to-one to receive additional support via a weekly SMS. This is just an example of an SMS a participant might receive. And then, so all participants were followed for 6 months. At enrollment month 3 and month 6, participants completed an interviewer-administered electronic survey to assess intervention uptake and acceptability. And then they also had blood collected at each time point to measure their HIV viral load. So participants were recruited from an HIV treatment clinic in a peri-urban township located in the Clipfontaine Mitchell's Plain Health Subdistrict near Cape Town. Participants had to be 13 to 24 years of age. They had to have regular access to a mobile phone with SMS capacity. They had to reside in the study area and be planning to stay for 6 months. And they had to be receiving their treatment or had received their treatment in the past year at the selected HIV treatment clinic. So enrollment occurred from February to October 2021, and this fully encompassed the South African Delta wave of COVID. And adolescents under 18 years of age had the option to waive parental consent, which they all took. Okay, so the objectives for this study were to examine feasibility, acceptability, and effectiveness of both the courier ART and the SMS interventions. So dichotomous exposure variables were created to describe the proportion of participants who were reported receiving an ART delivery via the courier service in the past 3 months at months 3 and 6. So this was an as-treated analysis. We also estimated the proportion of participants randomized to the SMS intervention at baseline, so that's your traditional ITT analysis. Our primary outcome was viral suppression, defined as HIV viral load, non-detectable or under 200 copies per milliliter at months 3 and 6. And we used modified Poisson regression with robust error variance to estimate the relative prevalence of viral suppression at each time point. Since participants were not randomized to the courier intervention, we did control for confounding, which included baseline viral suppression status and SMS randomization arm. So participants in our sample were a median age of 19 years. They did range from 13 to 24 years. And we did get a good portion of younger participants here. And our sample was 58% female. 37% reported food insecurity, and 22% reported they did not have regular access to soap or water, which was measured because this was during the pandemic. So a total of 227 participants were screened for our study. 215 were eligible. All eligible young people were enrolled into the study and randomized. Among all participants, 82% elected to enroll in the courier service at baseline, but 41% actually reported receiving a delivery of their ART via the courier service in the past 3 months at month 3, and 49% report receiving delivery in the past 3 months at month 6. So this is our as-treated exposure. There's a couple of reasons why participants who enrolled in the intervention didn't end up receiving delivery. Most just didn't complete the courier consent process. And some just decided to pick up their medication instead. And then there was a couple who did not happen to be due for medication during that time. And then so 110 participants, so about half were assigned to the SMS intervention arm or randomized to the intervention arm. Only 14 participants in the SMS arm, so 13% actually responded to an SMS message during follow-up. So that's how many engaged with SMS messages. And there was a median of 2 responses per participant among those who responded. So this table shows the intervention acceptability questions. The denominators here are the individuals who reported receiving each intervention at each time point. So we can see that 91, about to 100% of participants agreed or strongly agreed with the top 3 questions about the courier intervention acceptability. And then about 75 to 84% rated the SMS intervention positively across 4 acceptability questions, which we were actually interested to see because not a lot of people actually engaged with that intervention. This shows the reasons participants gave for enrolling or not enrolling in the courier intervention. So the most common reason was so that they wouldn't have to go to the clinic because it was easy or convenient. And the most common reason for not enrolling was they just preferred to go to the clinic and see their doctor, which we were fine with seeing. We were happy that it wasn't that they were worried about confidentiality or that they didn't trust the medication would be correct. So at baseline, 75% of participants had a suppressed HIV viral load, and then 76% had a suppressed viral load at month 3 and 80% at month 6. These numbers, especially the baseline numbers, are really reflective of our recruitment strategy. We did have poor participant retention, which resulted in missing courier exposure and viral suppression outcome data, which was expected to be missing not at random. Limiting our imputation options. We ended up employing a complete case analysis as our primary analysis. And then we also conducted a sensitivity analysis using the pattern mixture model approach to multiple imputation under the missing not at random assumption. So we basically assumed that participants with missing data were less likely to be virally suppressed or have received a delivery. And we applied various shift parameters to adjust imputed classification levels to try to account for this. Okay, so this is our preliminary effectiveness analysis. So in our regression models, we found that participants who reported receiving delivery in the past 3 months at month 3 were 1.26 times as likely to have a suppressed viral load at 3 compared to those who did not receive a delivery. And they were 1.21 times as likely to have a suppressed viral load at month 6. Though at month 6, that lower confidence limit does overlap the null. And there was no effect of receiving a delivery in the past 3 months at month 3. Sorry, let me start over. There was no effect of receiving a delivery in the past 3 months at month 6 on month 6 viral suppression. So we did not see an effect at month 6. And then our analysis examining the effect of randomization to the SMS intervention, we found that participants in the intervention arm were 1.34 times as likely to have a suppressed viral load, which was significant at month 3 compared to those in the control arm. But this effect was on viral suppression was again no longer significant at month 6. Okay, so I think in conclusion for this study, we found high acceptability and feasibility of the courier ARP intervention, as well as promising evidence for its potential effectiveness and increasing the probability of viral suppression, especially after 3 months. The randomized SMS intervention was also acceptable and effective in increasing viral suppression. So we think that this may have been an important support feature for adherence. So we think that these findings indicate that there may be promise for this delivery modality within DSD models and that a larger effectiveness trial of the courier intervention is warranted. So there's been 6 manuscripts from this study data. I've led 3 papers in total, including the primary paper shown here, which was published in JADES. We also co-enrolled a cohort of young people living without HIV, so there was about 540 youth total who received just the social behavioral questionnaire at baseline month 3 and month 6. So I did lead another paper examining exceptional reproductive health service utilization among young people living with and without HIV during COVID, which is shown here in contraception. This editorial on the right we published in Touch Reviews in Infectious Diseases. And here we discuss how the COVID-19 pandemic really accelerated innovations in healthcare access and allowed us to kind of reimagine the way that healthcare was delivered. So to fully transform HIV healthcare, continued research funding, collaboration, and research are needed to bolster evidence for differentiated models of HIV care at scale post-COVID-19. And then there's a PhD student at Karolinska Institute in Sweden who has led 3 additional manuscripts related to experiences of gender-based violence during COVID from our data for her dissertation. Okay, so our pilot study was not powered for individual level effectiveness. We were also not able to use a randomized study design given the funding mechanism and that the study was implemented during the pandemic. We really didn't feel like we could exclude participants from receiving this intervention at this time. Also, the majority of the sample was virally suppressed at baseline, which you saw. So we felt like we were potentially missing the youth who may have benefited from this intervention the most. So now to build on this work, we want to build on this work to evaluate the effectiveness of courier home art delivery among a cross-section of the art client population of South African young people living with HIV, including art-naive young people and non-naive young people who are in a treatment interruption. And we also want to gather data on implementation and cost effectiveness to better understand the context for future DSD implementation. So we submitted this R01 in May in collaboration with the Desmond Tutu Health Foundation and UNC. It scored well, and we've been encouraged to resubmit, which we're doing this upcoming January. So in this grant, we will first conduct qualitative interviews with providers and young people living with HIV to better understand what providers need to feel more comfortable with art being delivered to their non-clinically stable patients, and what would make young people more comfortable receiving deliveries, and really refine our implementation strategy. Then we will implement a multi-arm, parallel, individual randomized effectiveness implementation hybrid trial, which is such a mouthful. But basically, we want to examine the client-level effectiveness of the courier art delivery intervention, as well as the effect of treatment preference on HIV viral suppression at 12 months. So this will be analyzed similar to a doubly randomized preference trial, if you're familiar with those. So we will enroll 600 youth across 5 South African government art clinics, and participants will be randomized 1:1:1 to the courier home art delivery intervention and heated standard of care or choice arms. And we will utilize peer navigators to facilitate the intervention and deliver personalized and mobile adherence support to all participants. And then finally, we will conduct an evaluation of implementation outcomes, which will include a large cost effectiveness evaluation. Okay, so now for the last area of research I will discuss, which is leveraging population data to model the impact of social interventions on HIV and generalized HIV epidemic settings. So this research question was really developed more recently out of my desire to obtain more advanced data science skills to be able to model the population level impact of interventions on social and psychological determinants of health on HIV outcomes to kind of help me improve the policy relevance and potential public health impact of my intervention research. So since this is a newer area of focus for me, I'm primarily going to be discussing my plans for my newly funded KO1 award, but for just a quick background ahead of discussing that award. So in addition to having the world's largest HIV epidemic, South Africa was the country most severely affected by COVID-19 in Africa. And the COVID-19 pandemic, as we know, severely impacted several known risk factors for poor HIV prevention and care outcomes globally. So things like mental health and many social determinants of health. So the COVID-19 disruption presents this really unique opportunity to learn how significant shifts in key social and psychological determinants impact HIV outcomes in the context of this natural experiment. So exposure to the COVID-19 era. It can also allow us to examine the robustness of a model by assessing which parts of the model are most vulnerable to external disturbance and which model components, if modified, are likely to yield the most desirable changes in clinical outcomes. Okay, so just as an example of the potential impact of COVID-19 on mental health, we conducted this study among UNC Chapel Hill students during the pandemic. So this was just a cross-sectional survey that was distributed to all UNC students in June of 2020. And I weighted this data to the full student population, UNC Chapel Hill, I should say. using rating methods. So we found that almost 2/3, so 64% of students reported clinically significant depressive symptoms, and 65% were categorized as lonely. And this figure just shows the prevalence of mental health outcomes were associated with level of self-isolation. So for example, compared to those self-isolating none of the time, those self-isolating some of the time were 1.8 times as likely to report clinically significant depressive symptoms. And so students self-isolating most or all the time were 2.1 and 2.3 times as likely to report clinically significant depressive symptoms. So we obviously don't have a pre-COVID comparison here, but that prevalence of depression seems super high. And we can imagine that jump in poor health and well-being among students could have downstream effects. Okay, so as I mentioned, I have a KO1 that was recently awarded, and I just started in July. The mentors on this board are Patrick Sullivan, Donna Barrerio, Rob Crafty, all at Emory, and then Linda Gelbecker at DTHF, Lee Johnson, who's at UCT, and Brandon Marshall, who's at Brown. So during this 5-year award, I will first identify national data systems across South Africa that enable the generation of robust HIV, mental health, and social determinants of health estimates over time. So the first aim is really to create this giant population level database. And then we will conduct an interrupted time series analysis to examine short and long-term trends in HIV prevention and care outcomes, mental health, and social determinants of health prior to and during COVID-19 in South Africa. And then finally, we are going to extend an existing agent-based model to identify social and psychological factors that are predictive of HIV outcomes in the context of COVID-19. And we're also going to simulate the impact of changes on predictive factors to identify targets for hypothetical interventions. So that does sound overwhelming. I am overwhelmed. But the goal of this work is really to inform methods for understanding how we can intervene on social determinants of health to prevent disruptions in progress towards ending HIV/AIDS, using the COVID-19 pandemic in South Africa as this case example. So my training will surround techniques for harmonizing big data, quasi-experimental designs and agent-based modeling, policy engagement, and cost-effectiveness analysis. Okay, so these are just the grants that I've discussed today. The first two are active. The third is that R01 that we are resubmitting. These are some other grants that I've assisted with in a support role while at Emory as a co-I. So I won't go into detail on all of these, but I just wanted to quickly mention them. The first study listed is an R34 that was just recently funded. So in this study, we will adapt and pilot test the friendship bench mental health intervention to target both mental health and medication adherence among MSM living both with and without HIV in South Africa. The study below is an R21, R33, where we are proposing to develop and test an AI chatbot version of that friendship bench R34 intervention. So this one, this is a 5-year award. And it would be very exciting if it were funded to get them be able to kind of apply some of those methods that we learned, those AI methods that we learned to maybe improve the reach of some psychosocial interventions I can think of for adolescents and young people. So this grant was submitted to an RFA and it scored very well. We just completed our just in time. So I think this one will be funded very soon. And these last two are D43s, which as a global health researcher, I feel very passionately about contributing to. So I had the opportunity to help develop and write these this past August. And if funded, I will serve as a co-investigator. And then for both of them, I also have a role in leading their program evaluation. Okay, so.
Are those multi-institute awards, the D43s?
They're Fogarty.
They're Fogarty.
Yeah, they're both the Fogarty D43s. All the other grants are NIMH. Okay, so I just wanted to quickly run through some of my potential contributions as an early career faculty member. I think the first is through new collaborations. So this includes collaborators at the Desmond Tutu Health Foundation, the University of Cape Town, and UNC. So particularly DTHF is a great partner that I have had the opportunity to learn so much from throughout my career, and that not only supports collaborative research, but also provides tons of opportunities for student training and support for student research projects, which is really exciting. The second is my focus on a priority population for HIV research, so specifically South African adolescents and young people and young women. So the US government and a lot of private funding entities make substantial investments in HIV research in South Africa, and adolescents and young people require a significant portion of that research attention in order to end the global HIV epidemic. So in order to reduce HIV-related disparities among adolescents and young people, a lot of my research aims to target social and structural and psychological determinants of health. So my experience with interventions related to IPV, mental health, and differentiated service delivery potentially has applications to research aimed at improving other health outcomes or just improving health and well-being more generally. And then next is through multidisciplinary training, which includes EPI, causal inference, social behavioral science, and implementation science, as well as my interdisciplinary research, which seems to be a strength of this department. This really lends to, I think, forming new collaborations, and then also working with students from diverse academic backgrounds. And then last is through teaching, mentoring, and service, which I just wanted to quickly touch on. So I think the research and grants that I've discussed today provide a strong foundation to hopefully enhance the impact of my future teaching, mentoring, and service positions. So the top sections of each of these categories are show some examples of my experience so far, and the bottom is new areas where I would like to grow my experience. So for teaching, I have experience teaching a full semester length graduate level course, which was Intro to EPI Research Methods, which I taught at Brown. I've listed some topic areas here that I would be comfortable and interested in teaching in the future, and I was thinking of new courses that I could potentially create. One is an interventions course that's actually inspired by a course I took during my PhD, and this could cover methods for evaluating interventions, including randomized and non-randomized designs. And then for mentoring, I have some experience mentoring master's and PhD level students, although this is an area that I would like to start growing in. I strongly value mentoring through research. So on our studies in South Africa, we hire exclusively from the local communities to support local research careers. And then we also provide educational and career development opportunities to study staff during their employment. And I have provided recommendations for 2 employees from our DSD pilot study who are now in public health PhD programs in South Africa. And then last, for service, in addition to peer review for academic journals, I've also served as a protocol reviewer for the South African Medical Research Council for the past 2 years. And I'm currently a guest editor for a special issue at BMC Infectious Diseases. Some areas I hope to increase my service contributions, in addition to mentoring students, is to sit on department committees, assist with diversity, equity, and justice initiatives, and participating in NIH grant review programs, in addition to continuing my involvement with the CFAR. Okay, that's all I have. Thank you for your time. I'll have to talk back about it.
That was great. Thanks. Any questions for Danielle?
Yeah.
I'm Connie, I'm a second year PhD student, and my question was about the grant that you said you're resubmitting. So I guess with reaching populations that aren't engaged in clinic, like care in clinic, one of the challenges that I can think of is like, what I just blanked, ART, like resistance, thank you. ART resistance, so I guess while trying to engage populations like that, how are you balancing kind of the risk of having more resistance to ART while also making sure that they're, able to access these medications?
Yeah, and I think, you're definitely touching on like the concern of the providers when it comes to like why they don't want the medication delivered. I should have probably mentioned that. So even though they'd be getting their medication delivered, they would still have to come in for their regular HIV care visits. So those things would sit very separately. So they would still have to come in for their care visits, and the only difference is that their medication would be delivered. So that doesn't sound like a big benefit, but you have to come and get your medication like every 2 months, but you don't need to see your provider that frequently. And then you also don't need to queue in line at the pharmacy, which can be a very time-consuming process. And it's also kind of like a confidentiality and like stigma concern to be sitting in line at the pharmacy. So it kind of eliminates that aspect of it. And then also, yes, if you're missing your HIV care visit, presumably you're still getting your medication through the courier service. So those are kind of the benefits. We will have to look at resistance and kind of see if that's something that comes out of our project. A lot of studies that have been conducted of adults have not shown that. But this is kind of like one of the concerns with delivering to non-clinically stable patients. You're exactly right, is them. And newly diagnosed patients will have to come in and get their medication for a certain amount of time before they can be enrolled into this program. So that's definitely, you're thinking correctly, is kind of like the limitations of why they haven't been doing this. But then maybe people who would default just because they didn't want to go to the clinic could have their medication. So yeah, it's a good question. And something we're thinking about.
Okay, and a follow-up to that is, is there potential in that project to maybe do some kind of like at-home testing service as well for like viral load measurements? Because if the barrier is, like getting to clinic to pick up medications,
Yeah.
then maybe like a barrier is also getting to your appointment. So maybe that's something.
Yeah, and I mean, I feel like this could have gone so many directions because there's a lot of things like that. Like there's mobile clinics where they can do that. And there's also a lot of different other types of differentiated service. So you can think about putting things in lockers so people could just go pick up their medication at locker, which would be easier. So yes, I do think we should think about that. As far as like designing a trial, we had to kind of like be like, this is what we want to look at, is because we're still kind of like in the efficacy phase. Because the pilot wasn't randomized, I don't feel like we got individual level efficacy. So we're designing this very much as kind of like, individual level effectiveness trial, and also trying to inform as much implementation as possible. So hopefully kind of those barriers come out in some of the implementation and qualitative work. But yeah, we are thinking of those things as well, because you're right, that is potentially a barrier as well. So yeah. Thank you.
Yeah, no, I think first of all, congratulations, like lots of great success and really terrific work. I want to ask you a couple of questions. They're kind of conceptual questions, and they're sort of motivated by just the ongoing grappling with what implementation science might be. So the first question is, can you say a little bit more about why you're framing the first aim as optimization? What is it that you're aiming to optimize? I got some hints in what you said, but I'd like to hear you just talk a little bit more about that.
Are you talking about the RO1?
The first, you gave us 3 overall directions. One was optimizing prep with girls, designing. So the framing was optimizing.
Oh, I see what you're
And then I'll tell you the second one, and then you can take them to whatever degree you want. And the second one was, similar kind of question. It's framed as a structural intervention. And you answered maybe a little bit of it when you were responding to Kamini, but in what sense is it structural? So could you say a bit more about how you see it integrating the health system? Maybe some issues about how you're thinking about scale. Especially in a country like South Africa, where you have a constitutionally enshrined right to access to healthcare services. How are you thinking about that next step, and does that inform the way you're thinking about design and all, and when you're trying to do these things? And I know they're super big questions, but just since you frame them out that way, I'd just like to hear you thinking about that.
Yeah, and those are interesting questions. So first, optimizing PrEP implementation. I'm thinking of PrEP right now. We've made all these incredible advancements in biomedical HIV prevention. We have these incredible tools. And at this point, I feel like it's all about implementation. So that's kind of like where this work is focused. I specifically kind of described looking like social and behavioral determinants of implementation, but then I think, there's structural barriers to implementation and product and supply barriers to implementation. So yeah, I guess I'm wondering if implementation is the right word, but basically a lot of this work focuses on like using the tools that we have and making them more, how can we kind of provide these like tailored or differentiated or services in a way that are going to optimize uptake, adherence, use, and these outcomes that we would like to see.
So you get the right configurations of them, essentially, is what you're saying.
Yeah. Yes. And then the second question.
Yeah, well, just about the structural part. And
yeah,
I think we tend to not think a lot about the integration with health systems. And South Africa is a complex jurisdiction with delivery of health services.
Yeah, and implementing this pilot trial alone was like, in one clinic in South Africa was extremely challenging. So, I mean, I think of this as a structural intervention because we are addressing these like structural barriers to care, like actually walking to the clinic. One of the cost effectiveness pieces of the cost effectiveness analysis is to look at like cost savings to the patients as well, who are enrolled in the differentiated service delivery. So like the cost of them not having to take a taxi to the clinic. So I do think of this as like a structural intervention. As far as like actual implementation, I mean, that's something that I'm thinking about a lot. I do think that this intervention, if taken to scale, has potential for impact, which to me is really exciting. And I do think a lot of people, based on our acceptability data, would enroll in an intervention like this. So I think it has those pieces going for it. I think getting the like practicality pieces of implementing intervention like this is the difficult part. Who's going to pay for the courier service, right? Like, but if we find in our cost effectiveness analysis that if this were implemented at scale, it would like yield these like long-term savings to the health system, then I think there's a case for that. Yeah. I mean, I was just talking to you about how I want kind of like more training in these like kind of like policy engagement pieces so I can learn about these things. Because I think that that's a really important point. And my hope, this has been scaled in other contexts in Africa among clinically stable adult patients. So I think that there's work being done there and there's maybe like a model in the future. But this I feel like has so much like potential to move the needle, right? Because this is youth, you know, so
Yeah, and it's not a gotcha question, because I think we're just trying to
No,
figure out
yeah.
at what stage in the design and thinking do you start entertaining those kind of ideas. So thanks.
yeah, I mean, it's just, to me, it's been about like thinking more simply, like as opposed to multi-session, very long, intricate interventions that I feel like are gonna be hard. Like, this is like, can we just deliver it to their door and then will they take that? I think for some people that will work. It's just like, if we did that at scale, what is that impact and is it worth it? Yeah, and I have hope that it will, especially for you. They don't wanna go to the clinic, you know? So, yeah,
Thank you.
thank you. Any other questions?
Question. Hi, I'm Josh. I'm a new faculty in the department, so I know where you are from. And you have done amazing work. You have, really, your research is so interdisciplinary, as you were saying. You have such a clear focus on what you are trying to do, and you're building on so much. Like all of your studies connect. So, congratulations.
Yeah.
I am not familiar with the HIV kind of research, so all of this was really new for me. But I do know that governments have prioritized this much more than, for example, child development or parenting. And so I'm curious how, in your work so far, and with Jim's question about scale, how government has come into some of the projects you've worked on, and where they are aligned and where your work aligns with ongoing either national policies or other large-scale interventions.
Yeah.
And what of your work is kind of more just scientific and how that policy piece comes in?
Yeah, I mean, that's a great question. I think that like these pieces, so I talked a little bit about IPV, and there's the other study on mental health, although that's among MSM. Those are two like very high priorities in South Africa. South Africa has the highest rate of femicide globally. It's a major public health concern. Kate's gone. We were just talking about this. There's a lot of research money in this like HIV space that I'm not sure is for other contexts like South Africa would be available for like through these NIH funding mechanisms. So a lot of the work I do, I'm very interested in just improving these like resilience resources for IPV. I also do want to improve, reduce, HIV risk. But yeah, so that's in some ways I feel like I'm like navigating through the HIV funding sources to also try to be like, we need to target these other things, like we need to think about mental health, violence. We can't just be like solely thinking about HIV when a lot of times we go to these youth in our CAPs or community engagement events and we talk about we talk about HIV and they're like, we have all these other problems, so I think it's like those things that are kind of like these national priorities in South Africa, trying to combine them, I think, and integrate them into our research as much as possible has been something that I've been trying to do. Yeah, does that answer your question?
Yeah.
It's a good question. Thank you. Thank you all for coming.
Thank you.